I'm not going to show you all the pre-op stuff and the Aura. I use Aura. My pre-op IOL Master 700, Cassini, iTrace, TORIC program. I'm a big crystalline TrueLine user, and this was something that happened after the fact. This is a post-LASIK patient, and this is where my practice is. I mean, plain and simple, my practice is, you know, absolutely mostly post-refractive. And Ray stays up at night because of me, and
in a good way.
in a good way, in a good way, and I want to thank Sonia and Ray, and I was going to give up on iTrace a few years ago when I bought it. Damn, Steve. And that's what I used to say, and I have learned that this is the most invaluable tool you could ever possibly have. Now, there's so much information, and for me, I'm a cataract refractive surgeon. I do not do LASIK. I do not do PRK. I do not want to do SMILE. I want to do none of that. I want to take the cataract out and do the best job I can to get the best results, and I don't want to send them anywhere. I was going to give Kathy McCabe a little bit of credit because she is my cleanup girl, but she hasn't had to clean up for me in a long time. And it's a really nice feeling to get to this point in my career, and I've done this for 30 years. So you could teach old dogs new tricks, and old dogs new tricks, you know, I mean, come on, you know, and I mean, we can learn a lot from this stuff. The iTrace, to me, you know, somebody said something about a pentacam. I said, that makes me throw up to look at a pentacam because it gives me so much information. So does the iTrace. However, if you're smart enough to utilize the people that know this machine and call Ray 9,000 times, and I have a great tech who is Saray, I have to give her credit, and she bugs him way more than I do. I tell her, but she also has already bugged him before she's ever done anything. So there's so much information on this iTrace, and it's a learning process. That's why we're all here, because every time we come to this, somebody gives us information that we learn something from. So, pardon me?
She said, that's you.
Oh, excuse me.
That's you.
Okay. So this is my nightmare. This was what happened. This is a guy, and these are my financial disclosures, not that I matter. Okay, so I highlighted the red things, you know. He's an engineer. Okay, had LASIK 20 plus years ago with a blade, okay? He has increased tear breakup time. Oh, the other thing too, he was a monovision, and his right eye was for distance, and his left eye was for near in the past, and now it's the other way around. His his left eye is now distance, and his right eye is now near, if you will. And he's minus in one eye and plus in the other. Increased tear breakup time, no corneal scarring from his LASIK on exam. The company description of 0.7, is that because he's a myope? His Pachy was fine, his pressures are good, his actually did a visual field and it was normal. He had mild ERM, but it was a little bit to the right of the macula, so it really wasn't bothering him. And this is very important, no muscle imbalance on measurements by history. So I do, a Maddox rod on patients and worth 4 dots and all that kind of stuff, because I was taught that by John Wells, whose son is the chairman at USC, where I did my training. And it's been an invaluable tool. If they have double vision or they have aphoria before you do surgery and you tell them, you're the hero. If you do not tell them, they hate your guts and they're going to go down the street. So those are really good pearls that I live by. So this is this gentleman's right eye, I believe, yes. And you know, he's got, his DLI is 2.21. He's got a little bit of corneal issues, but he's got a cataract. So we're going to take his cataract out. This is the just the WF and CT summary display. That gives you a lot of information. You know, astigmatism, bad refraction. You know, and his cornea doesn't look great. He's got like an inferior kind of thing going on in his cornea, and but it's an old, you know, an old LASIK. So this is his post-op journey. So post-op, I did his surgery in October. In November, he was 20/20. At distance, 20/20 at near, or 20/20 intermediate, J3, but he had shadows and double vision, but mostly at night. Okay, so I've already pre-treated him because he had dry eye and post-op LASIK. He had already been treated for 2 months with Restasis before he did his cataract surgery. Christmas vacation comes around and he goes out of town to Michigan or Ohio or wherever he's from in the Midwest, and he comes back, calls me and says, or actually he didn't call me, he just came in for his post-op appointment, and he's 20/30, 20/25, and J8. Double vision all the time, terrible vision. Terrible, terrible, terrible vision. And I'm like throwing up in my mouth. And I'm like, and he's that engineer where he like grows a beard because he's stressed engineer. He doesn't say, and he's got that personality where he's like, he becomes all depressed and his posture changes and all kind of stuff. And then the next time I see him, he's all clean shaven and he's standing up straight. So he's a really kind of odd bird. So this is his eye trace. And he now has, and Ray, I can't read that. He has 4 diopters of astigmatism. Okay, and his DLI went to 2.10, and it was at 10. And I'm looking at this, and he's got all this astigmatism. And of course, the first thing you're going to think, he's got a true liner, crystal lens, accommodative lens. He's got vault. Well, that is not the case. I've done thousands of these. I've had 1 vault, and it's because I left cortex in the eye. Removed the cortex, the lens went posterior. So I'm flipping out. So I said, Ray, I don't know what to do. What am I going to do with this guy? Is it his cornea? Am I going to get sued? I mean, all these things, and I'm telling you this, and this is not a conversation I would have with people I don't know, but I know Ray. And he says, wait a minute, let's look at this. So we evaluated, and just so happens at Bobby Osher's meeting, we got the creme de la creme, Bobby, but Warren Hill, who's just a genius. And he says, and I just sat in his astigmatism course, and I said, let's show this. And he goes, no. Ray said, wait a minute. Hey, Warren, come here. Warren comes over and says, hey, Ray, what's up? And he says, can you look at this case with Dr. Stephenson and I? And so he said, oh, this is an accommodative lens, and the patient has capsular fibrosis, and you need to YAG this patient. And I said, oh, really? Really? Because his vision's pretty good. He had a little bit of stria, and I was like blown away. Okay, so I YAG him. Okay? But let me just make a point. Look at his refraction. -2 plus 175 at 83. That was almost his pre-op refraction. But now his vision is terrific, okay? So, I did all the other stuff, the medical legal stuff. The lens is perfectly centered. There's no tilt or whatever. I did the TORIC check, and at 25 degrees, come on now, a quarter? Like I'm gonna really bother with that? I mean, really, so you have to, don't let this lead you for everything you do. Use this as a tool for some things, because if I'd gone in and messed with him, I'd have made him worse, and then I would not be standing here. I might have had to, be treated and put away. And, so as time goes on, as time goes on, I'll share the rest of this story with you. So this is his pre-op on his left eye. Not much of a cataract, but he complained because he had a PSC cataract. Very nominal amount of astigmatism, but it's against the rule, I think. Oblique. And so this is his journey again in his left eye. And he was 20/25 distance, uncorrected, intermediate 20/20, J2, but he had shadows and diplopia. Again, because I thought once I took his cataract out of his other eye, all that stuff would go away. I'm still treating the surface. I'm still doing all that stuff. Christmas vacation comes around, he comes back, and now his vision is 21/50, 20/25 at intermediate, and J5 at near, and he's worse, terrible vision. So here is his eye trace. And look at his DLI. It's a 2.93. So again, this is also, I showed to Warren because it was all in the same time frame. And look at him. So now he's, his spherical equivalent is like minus, 0.4, which he should be happy, okay? So this is, I treated this guy, and this is good. I mean, I feel really good about things. The lens is centered. 1 degree of rotation would give him nothing and put him down to 0.13, and he's at 0.12, and all it did was change the spherical part of it, So now, this is currently what he is. And this is literally like last week. Uncorrected 20/30 in the right eye, 20/20 intermediate, nears J3. So this is his refraction. Okay, and it makes no sense to me that his refraction is this, even though the spherical equivalent's like, -1, if you will. He shouldn't be. That's too much minus, and he liked it, but he doesn't want to wear glasses. So his left eye is 20/25, intermediate, J3 and near. you know, that all fits, you know. So, but together he's 20/20, intermediate 20/20, near is J3+. Now that's good results on a post-LASIK patient from 20-something years ago. Still has the symptoms, only at night, but he thinks he can live with it. Now, if I give him a refraction, he sees good, and the double vision is everything. The images are pretty darn good. He really likes it. But I'm not wearing glasses. I came to you not to wear glasses. And he wants to have a corneal procedure to see if we can make things better. So I'm like, okay, but I don't do that. So he actually is going home for the summer. So I said to him, let's do these 3 things. Continue treating your dry eye, wear reading glasses if you need to in bad lighting, but keep working at your near exercises, you know, for accommodative lenses. I make them do it up to a year. And I'll talk to your LASIK doctor that did your LASIK with a guillotine 20-something years ago. Because he talked to the office maybe 6 to 8 weeks ago, and the nurse said to the patient, of course we can fix your cornea, and you'll be 20/20. I'm like, okay. So this has been a nightmare. Every time this guy comes to my office, I'm sick to my stomach. He's not mean, he's not unkind, he's very grateful that I've taken so much initiative to present his cases so many times, but the point being is, iTrace has been invaluable. He's an engineer, he gets those pictures. And I show him, it looks terrible, I laser him, it improves, he does pretty well for a while till his brain takes over, and then he says, well, how come I'm not seeing good all the time? Do you see well sometimes? Yeah, I really do. Sometimes I see great. At night, it's a lot worse. And I said, well, this is really your cornea? This really isn't. And I've told them since day one, but these are the kind of things patients want proof in the pudding. And you can really utilize iTrace in that respect, but it also has helped me, and it also helped me know that I didn't do the wrong thing for this guy. I did the right thing for this guy. And angst is a big, big issue with all of us.
So when you gagging the account for phimosis or leukemia?
No phimosis. There was no phimosis.
I think you said
No, I didn't say phimosis. Nope, just posterior subcapsular cataract. I mean, capsular fibrosis, not phimosis. What's his pupil at night? It doesn't, you know, it's probably, I've not tested it at night, but what I did is I did him a whole thing with Alphagan. He would not take it. And he said, it didn't help me. And I said, Lyle, did you take it more than one time? He goes, no, but it didn't help me. And I said, you need to try it for like a week or 10 days. He goes, I really don't want to, because it really didn't make any difference. Okay? You know, I asked him to get a pair of glasses just to see. And I said, I will even pay for the glasses. He said, I'm not wearing glasses. Well, that's a great idea. That's great. Give him a headache on top of it. Yes?
Are you being more aggressive with gags now that you have the iTrace? Because sometimes you see capsules that don't look that impressive, but people have visual symptoms, and then you see the DLI.
Right. Well, I will tell you this. Crystal lens and Trueline, YAG often and early. Always. And you'll be surprised, any premium lens, any stria or anything that's going to bother the visual axis needs to be yagged. And you'll be amazed when you go to do the yag, all of a sudden that clears up and you go, well, if that was my eye, I would certainly be seeing better. So I think yagging these patients is a real must. And I think a lot of us make a mistake I'm by myself, so I see all the questions, I do all the questions and answers and all the complaints and the happiness. And I see my patients a lot more often. Yeah, yes, a lot more often. And I do yags when I need to. Yes? Yes. Well, I've never heard of it either, but Bill Trattler is a dear friend of mine, and George Waring and Carolina are great friends, and this guy has an unstable cornea. I mean, plain and simple. So cross-linking is going to make his cornea stable. So, maybe. Well, it's working because now his fluctuation from 6 o'clock in the morning to 8 o'clock at night is a half a diopter. It was 2.5 to 3. So it works. It works. It worked on this guy anyway. And I have 7 other patients that have been sent. So we have a paper coming out. So hopefully it'll answer some questions. But you know, it's anecdotal. It's not all science. But thank you all. Thank you, Ray. As always.